This last section introduces some additional biomarkers that can enhance cardiovascular risk assessment. These tests are often used in integrative and preventative cardiology, and they can help identify inflammation, clotting risk, and even endothelial dysfunction or even ongoing thrombus formation. They're not primary screening tools, but they can be very helpful in borderline cases or even complex cardiometabolic patients. These biomarkers, HSCRP, which is different from the high sensitivity CRP that we looked at before, or the high sensitivity troponin that we looked at before, I should say, homocysteine, fibrinogen, D-dimer, and bleeding time can help refine cardiovascular risk assessment beyond the standard lipid panel. HSCRP reflects vascular inflammation and is strongly associated with atherosclerotic plaque activity. Homocysteine elevation is linked to endothelial dysfunction. Fibrinogen reflects both blood viscosity and clotting potential. D-dimer is a helpful rule-out test for an active clotting event. And bleeding time gives insight into platelet function. While none of these are first-line screening tests, they have become important in complex cardiometabolic patients or when traditional lipid testing does not fully explain the risk profile. This slide reviews the Fredrickson classification system for hyperlipidemia types 1 through 5. These are primarily genetic disorders affecting lipoprotein metabolism. Type 1 reflects elevations in chylomicrons. Type 2 is LDL dominant and includes familial hypercholesterolemia. Type 3 involves IDL elevation, and type 4 relates to VLDL excess, and type 5 involves both chylomicrons and VLDL. The table also lists appropriate therapeutic approaches such as a low-fat diet, low cholesterol diet, niacin, weight loss, and fibrates. And while these disorders are more rare, knowing the patterns can actually help you identify severe or refractory dyslipidemia. Some other independent biomarkers, the same ones that we listed before, HSCRP, homocysteine, fibrinogen, D-dimers, and bleeding time. Just kind of in practice, these markers can help assess inflammation, thrombosis risk, endothelial health, and coagulation abnormalities. They can be especially helpful in patients with premature cardiovascular disease, autoimmune conditions, or even elevated risk despite a normal standard lipid panel. Some gene variants that are present can influence cholesterol metabolism, hypertension, and methylation pathways, as well as coagulation. Examples include variants with ApoE proteins, which affect cholesterol transport, MTHFR, which can affect homocysteine metabolism, and factor 2 and 5 polymorphisms, which can influence clotting risk. Understanding some of these polymorphisms can guide personalized risk assessment and therapy. While not universally used in practice, genomic polymorphism testing is increasingly relevant in integrative and functional cardiology. Several gene variants also influence blood pressure regulation. GNB3 or guanine nucleotide binding protein 3 affects G protein signaling and vasoconstriction responsiveness. AGT or angiotensin encodes angiotensinogen, impacting ROS activation, and AGTR1 encodes the angiotensin 2 type 1 receptor, which is a major regulator of vascular tone. Polymorphisms in these genes can predispose patients to high blood pressure and change how they will respond to medications, which understanding these then can help tailor treatment, particularly in treatment-resistant hypertension. GNB3 matters clinically. The GNB3 subunit plays a central role in cell-to-cell signal transduction, including signaling pathways activated by angiotensin 2. Overactive signaling increases vasoconstriction and contributes to hypertension. Patients with certain GNB3 variants may be more salt sensitive or may respond differently to antihypertensives. This is part of the growing understanding that hypertension is not a single disease, but a collection of phenotypes influenced by genetics. The 825C T variant is associated with essential hypertension and obesity. This polymorphism appears to increase susceptibility to vasoconstriction and may amplify blood pressure responses to stress and sodium intake. Recognizing this variant explains why some patients develop hypertension early or respond poorly to lifestyle changes alone. Genetic context helps individualize risk, counseling, and treatment intensity. Now, this slide kind of is helping us connect how can we use these clinically because it connects us to pharmaceutical intervention. Individuals that carry one or two T alleles respond more strongly to thiazide diuretics. This means that for some patients, thiazides may be the most effective first-line therapy. It also mentions that herbal diuretics, such as dandelion leaves, could offer a complementary option, although evidence is more limited there. So, understanding pharmacogenetics can help optimize medication choice and avoid unnecessary polypharmacy. Angiotensinogen is produced by the liver and converted into angiotensin 1 and 2 throughout the ROS cascade. Angiotensin 2 is a potent vasoconstrictor and promotes sodium and water retention, which increases blood pressure. Variants in the AGT gene can increase angiotensinogen production, pushing the system towards chronic hypertension. This is especially important in patients with strong family history of hypertension, specifically in early onset disease. The M235T variant is associated with higher angiotensinogen levels and approximately double the risk of essential hypertension and coronary artery disease. This explains why some individuals develop high blood pressure even with modest lifestyle risk. Identifying this variant may influence early intervention strategies and justify more aggressive preventative therapy. When patients with hypertension were placed on a sodium-restricted diet, their blood pressure responses varied based off of their AGT genotype. Those with T alleles had greater blood pressure reduction in response to sodium restriction, which supports the idea of precision nutrition, that dietary recommendations are not one size fits all, and some individuals are much more salt sensitive than others. The AGTRI or R1 is the primary receptor through which angiotensin 2 exerts its vasoconstrictive and sodium retaining events. Variants in this gene can increase receptor activity and predispose individuals to high blood pressure and cardiovascular disease. This receptor is the target of ARBs like losartan, which block angiotensin 2 signaling. Understanding AGTR1 polymorphisms helps individualize treatment, especially in patients who respond unusually well or poorly to ARBs. The 1166A to C polymorphism in the AGTR1 gene increases the binding affinity of angiotensin 2 to its receptor. This leads to greater vasoconstriction and sodium retention, producing a stronger hypertensive response. Clinically, this variant is linked with higher rates of essential hypertension and early onset or increased cardiovascular risk. When you see patients with early onset or resistant hypertension, genetic factors like this may be contributing. Understanding this polymorphisms can help explain why some patients respond dramatically to certain medications and others don't respond at all. Speaking of medications, this slide demonstrates a clear example of pharmacogenics in action. Patients with the AC or CC genotype showed significant improvements in GFR and decreases in mean arterial pressure when treated with an ARB like losartan. In contrast, individuals with the AA genotype had a minimal response. This means that genetic variants can strongly influence therapeutic efficacy. In the future, genomic screening may help guide antihypertensive secretion and selection in the same way that pharmacogenic testing guides antidepressant or oncology treatments today. Bleeding time, we discussed earlier this term, but it's an older test, but still valuable for understanding platelet function. This slide shows the setup, a blood pressure cuff inflated to 40 millimeters of mercury to standardized pressure, followed by a controlled incision on the forearm. Bleeding time assesses platelet plug formation, not the coagulation cascade. If platelet count and fibrinogen levels are normal, a prolonged bleeding time suggests qualitative platelet dysfunction, such as in von Willebrand disease or medication effects like aspirin. Although not commonly used, it's helpful conceptually for understanding primary hemostasis. A small standardized incision is made in this test, and time to cessation of bleeding is recorded. Normal bleeding time is between 2 to 10 minutes, and times under 3 to 4 minutes indicate hyperactive platelet aggregation and may correlate with thrombosis risk, whereas prolonged time suggests platelet dysfunction because it reflects real-time, real-life platelet behavior. Bleeding time can capture disorders that are routinely missed on labs. While replaced by more modern assays, in many settings, understanding bleeding time provides insight into clinical bleeding and clotting cascades. The overall goals of lipid and cardiovascular risk management are to lower triglycerides, total cholesterol, LDL, and LPA while increasing HDL and ApoA. We also want to keep homocysteine and fibrinogen within healthy ranges. Bleeding time should be around 6 to 8 minutes, as lower values suggest clotting risk, while higher values can uh, or lower values suggest excessive clotting risk, especially when combined with elevated fibrinogens or LPAs. The slide also highlights that overtreatment can increase bleeding risk, and so therefore we must balance coagulation, inflammation, and lipid metabolism to prevent atherosclerosis and thrombosis. And here are some key references that you can look through, supporting guidelines and evidence presented in earlier slides on troponin accuracy, BNP interpretation, diagnostic pathways, and ACS and heart failure. Ultimately, when looking through these different studies and labs, my goal is for you to have a really solid understanding of your basic lipid panel with cholesterol, triglycerides, LDL, and HDL, and then understand the troponin types. And if you can add one more thing to your brain, BNP would be a good one to add. The popcorn labs aren't as important or vital for this class at this time.